Hello, good morning. Hope you are all well. In this month, Corona third phase has started. Be careful, take own care and stay disease free. Today's subject is lymphadenopathy and lymphedema. It is related to the lymphatic system already, which you have studied in your first, second, third and fourth semester, and now you have started reading pathology. So, it will be very good time to have a understanding of the clinical side of lymphadenopathy and lymphedema. One day we will become either a surgeon or physician or gynecologist or pediatrician, but you have to know, if you are even a general practitioner, this lymphadenopathy means swelling of the lymph nodes with different types of presentation will come to you. So, you have to understand and make mind for these diseases which you will often encounter in your daily practice, lymphadenopathy and lymphedema. Now, I will start lymphadenopathy. So, how will approach a case of lymphadenopathy? First, you have to know how many lymph nodes are there. Approximately there are 600 lymph nodes in our body. Starting from head, neck, you go down, there is submandibular lymph nodes, cervical lymph nodes, left submandibular, submental, then axillary lymph nodes, then lymph nodes in the abdomen, lymph nodes in the inguinal region, etc. And moreover, it also consists of tonsils, then in the intestine, Peyer's patches, spleen, thymus, all those things. There are some lymph nodes which are normally palpable. What are those? Submandibular lymph nodes, axillary lymph nodes and inguinal lymph nodes. And in the face, preauricular, parotid, and in the neck, anterior cervical, posterior cervical. In the inguinal region, in the groin, you will find these inguinal lymph nodes. In the axilla, in the armpit, lymph nodes are formed. Now, what happens? Pathophysiology. Now, these lymph nodes are for our protection against disease. That may be bacterial disease, viral disease. So, any sort of infection, you know the structure of the lymph nodes. There are cells which protect our body and produce antibody against bacteria, viruses, etc. And moreover, so when the body is under threat, then there occurs hyperplastic reaction in the lymph nodes. Body responds by increasing the cells and other things in the lymph nodes to protect the body, and that is hyperplastic response. If it is a simple type of infection, it resolves within 1 month. Now, these are the pictures of the lymph nodes. You will see when we do pathology study of the lymph nodes and reactions to different types of bacterial, viral infections, and also in malignant changes. You will see different types of slides which we will have to read, memorize, and to understand it. Now, what is the clinical presentation? Lymph nodes may be palpable, but if it is below 1 centimeter, it is called subclinical. Then pathologically it may not be significant. But if lymph nodes are more than 1 centimeter in size, it is abnormal. So, size is very important, more than 1 centimeter. And lymph nodes palpable in other regions means when in some sites I have told you, like cervical and inguinal lymph nodes are palpable, but if other regions, in other regions lymph nodes you find, then it is called abnormal. And when you are examining, if the size of the lymph nodes is more than 3 centimeter, first you think it is a neoplasm, means cancer malignancy. In this picture you see the supraclavicular lymph node which is more than 3 centimeter in size. So, your first suspicion will be malignancy, and you have to exclude malignancy, then you will be able to treat properly. Now, with lymph nodes there may be accompanying symptoms which are very important. What are those? Recurrent fever. Patient is having fever for 3 weeks, 4 weeks or 6 weeks, temperature is more than 38.5 degrees centigrade, there may not be night sweats, history of weight loss. If those are available, you think it is lymphoma, means one type of malignancy of the lymphatic system. Maybe Hodgkin, non-Hodgkin or other things. When you do general examination, you have to look for the spleen. If spleen is enlarged and lymph nodes are enlarged, then it is more towards malignancy. Now, distribution of the lymph nodes, whether it is generalized. Generalized means you see in the neck, axilla, both sides, you have to see whether it is one side or both sided. Now, what are the causes? If it is originated from some infection, generalized lymphadenopathy, then underlying cause may be AIDS or AIDS related complexes, toxoplasmosis, secondary syphilis, infectious mononucleosis. Then if it is neoplasia, then leukemia, Hodgkin disease, non-Hodgkin's lymphoma. If it is hypersensitivity, that is body reacting to some foreign proteins, there may be hypersensitivity reaction, serum sickness, phenytoin, medicine. From medicine, there are some medicines which may cause this enlargement of the lymph nodes, and one of the example is phenytoin. Then vasculitis, lupus, rheumatoid arthritis. Then there may be metabolic causes, hyperthyroidism, Lymphoedosis. Now there is one disease called Castleman's disease. It is very rare, cause idiopathic. It is localized or multicentric, mimicking lymphoma, HIV infection. There may be some systemic symptoms, increased risk of infection. Now we have told earlier the generalized lymphadenopathy, now localized. Localized where? Anterior auricular, anterior to ear. What may be the causes? Viral conjunctivitis, trachoma, tularemia, sarcoidosis. If it is behind ear, post auricular, cause may be rubella, scalp infection. You see the picture of anterior auricular lymphadenopathy. This is ear, and anterior to ear is anterior auricular group of lymph nodes. Here this is lymph node situated posterior to ear. It is called posterior auricular. So anterior auricular causes viral conjunctivitis, trachoma, tularemia, sarcoidosis. And in case of posterior auricular lymph node enlargement, this may be rubella, may be scalp infection. Now submandibular. If the submandibular groups of lymph nodes are palpable, so origin may be buccal cavity infection, means oral cavity, infection of the root of the tooth, or maybe pharyngitis, nasopharyngeal tumor, thyroid malignancy. You may get submandibular enlargement. Then cervical, bilateral, means neck. If both sides lymph nodes are palpable, that may be due to infectious mononucleosis, sarcoidosis, toxoplasmosis, pharyngitis. You see the picture of the submandibular gland. This is chin, these are the ears, so this is submandibular gland. Then cervical, bilateral, right cervical, left cervical, lymph nodes are enlarged. Now you may get right supraclavicular glands enlarged. What may be the causes or source? Pulmonary malignancy, means malignancy of the lungs, trachea, etc., or from the mediastinum, mediastinal malignancy, or esophageal malignancy, CA esophagus. If it is palpable on the left supraclavicular region, it may be from intra-abdominal malignancy, from abdomen. Different structures in the abdomen may be affected due to malignancy, and that spreads to left supraclavicular region. Renal CA means malignancy of the kidney, malignancy of testis or ovary from pelvis. Right supraclavicular gland is shown here, the marked. Then left supraclavicular lymph nodes enlargement in this picture. So you have to first see the lymph nodes, palpate, and you have to mention which size of the site is affected. You have to mention it, and according to the site there are the causes which I have told you earlier. That is right supraclavicular, pulmonary, mediastinal, esophageal. Left supraclavicular, intra-abdominal malignancy, renal CA, testicular or ovarian malignancy. Axillary region. Which side of the axilla? What may be the causes? First is CA breast. CA breast is very common, and axillary lymph nodes often you will get arising from the CA breast, or infection, mastitis, upper extremity infection. Then you may get epitrochlear in the forearm. It cause may be syphilis. There you will get bilateral lymph nodes. Chronic lymphatic leukemia, infectious mononucleosis, lymphoma, hand infection, unilateral or same side. Axillary lymph nodes. These are the axilla. This is axilla, and in this picture you can see enlarged lymph node. Epitrochlear lymph node. You see just above the elbow, this epitrochlear lymph node palpable. Then we are going to inguinal region. Causes may be syphilis, genital herpes, lymphogranuloma venerum, chancroid, lower extremity or local infection. Lower extremity infection is very common in our country because people move barefoot. They do not use shoe or chappal. So often a good number of people in our country suffer from this lower extremity infection, for which you will often find inguinal lymph nodes are enlarged. You see in this picture, these inguinal lymph nodes in the groin region, swollen area, these are the inguinal lymph nodes. Then hilar lymph nodes, it is inside chest, unilateral or bilateral. One side of the hilar lymph nodes may be enlarged or both sides may be enlarged. So if it is unilateral, what may be the cause? Lymphoma, bronchogenic CA, tuberculosis, sarcoidosis. Then in case of bilateral hilar lymph nodes, both sides of the hilum affected. What may be the causes? Sarcoidosis, fungal infection. What are the fungus? Histoplasmosis, coccidiomycosis. Malignancy, lymphoma, bronchogenic CA, tuberculosis. Now in this picture, these two chest X-ray, you look, unilateral hilar lymphadenopathy means this marking they have shown, this is one-sided hilar lymph nodes enlarged, unilateral hilar lymphadenopathy. And I have told you causes may be lymphoma, bronchogenic CA, tuberculosis, sarcoidosis. Then in this picture, both the hilar lymph nodes are enlarged. Causes, I have told you, sarcoidosis, fungal infection, lymphoma, bronchogenic CA and tuberculosis. So when you get a chest X-ray, and obviously it is part of the investigation in case of lymphadenopathy, if you see these pictures, so automatically you have to exclude all those diseases to come to a diagnosis. Then abdominal lymph nodes. If abdominal lymph nodes are palpable, source of the infection mainly malignancy and tuberculosis. Adenocarcinoma of gut, any part, from stomach, small intestine, large gut, rectum, anal canal, you may get abdominal lymph nodes involved, enlarged. It may be from Hodgkin disease, and very common in our country, tuberculosis. Then bladder carcinoma and gastric carcinoma, I have told you. Now there is a very interesting thing, this is called in the name of one sister. All the inventions in medical science are made by doctors, but this one first noticed by Sister Mary Joseph. nodules, lymph nodules near the umbilicus, and she observed it for a long time, and then it was recognized and established that this lymph node is enlarged from gastric CA, and it is known in the name of Sister Mary Joseph nodule. Now, any region of the body you may get lymph node enlargement, lymphadenopathy, and causes are like this: cat scratch fever, Hodgkin disease, leukemia, metastatic CA, sarcoidosis, granulomatous infection. What are the granulomatous infection? Tuberculosis, syphilis, etc. Associated with this lymphadenopathy, some other lymphatic abnormalities may be noticed. This is lymphangitis, means lymph channels which are draining lymph from different parts of the body to lymph nodes may get inflamed. It is called lymphangitis. Enlargement of the lymph nodes called lymphadenitis, and when the supply and transport of lymph is getting obstructed, then there is collection of fluid in the tissue spaces, causing swelling of the part, especially limbs, affected limbs, one limb or both limbs, upper limb, lower limb, that is called lymphedema. Now, when you are approaching or one patient has come to you with history of lymph node enlargement, lymphadenopathy, you have to take history and examine properly. First, you determine whether this palpable mass a lymph node or something else. So, in the pre-auricular region or post-auricular region, it may be due to swelling of the parotid gland. So, you have to exclude. Then in the midline in the neck there may be swelling. So, thyroglossal cyst you have to exclude, or there may be a simple abscess. A tense abscess may feel firm to hard, but it is not lymph node. Branchial cyst, this is a congenital abnormality, and whether this swelling is acute or chronic, whether this swelling has appeared very recently or it is there for a long time and slowly increasing in size. Then character of the enlarged node. During clinical classes, we have told you how to examine the lymph nodes, what are the points you know, but just some points I am mentioning, whether that lymph nodes or swelling is tender or not, whether swelling is mobile or fixed, and consistency, whether it is firm, is rubbery or non-tender, and whether it is painless and feeling, how it is. It may be soft, it may be stony hard, it may be fixed, you cannot move it, or one swelling, one lymph node is attached to another lymph node and to adjacent lymph nodes, so it is called matted. Whether this lymph node swelling is localized or generalized, means in the neck it may be right side of the neck or left side of the neck, or in the inguinal region one side, or generalized from neck to groin there may be lymph nodes, axillary lymph nodes, all may be palpable, that is called generalized, or abdominal lymph nodes are enlarged. So, you have to differentiate localized or generalized. This is very important for mainly Hodgkin disease in staging, clinical staging and pathological staging. This is important. Then whether these swellings are associated with systemic localizing symptoms and signs. Systemic involvement, then localized symptoms. Localized means giving pressure, local effect, pressing nerves, paralyzing, and whether unusual epidemiological clues, exposure to cats, that is cats scratch fever, history of travel. Nowadays history of travel is very important. You know this recent coronavirus disease. So, if a man travels to tropical countries, in our country some regions like Odisha, you may be affected by filariasis. So, travel history is very important. Exposure to bird droppings, laceration during gardening, exposure to tuberculosis, whether family members or working atmosphere having another TB. So, there is history of tuberculosis, sexual exposure for syphilis, etc. Then you have to go for laboratory investigations, complete blood count with differential count, atypical lymphocytosis, eosinophilia, pancytopenia, serum uric acid, serum liver chemists, then localized adenopathy, only local group of lymph nodes, single or multiple local involvement. Then you need throat culture, urethral or cervical swab, blood culture. Last is biopsy. You have to take the lymph node out and examine, histopathological. Then abdominal CT. Actually abdominal lymph nodes not very well delineated. Through only CT abdomen examination we can know exactly which group of lymph nodes are affected, and that helps us in diagnosing and staging the diseases. Then bone marrow biopsy, that is also important to diagnose bone marrow diseases. Generalized adenopathy, serological test, VDRL, heterophile antibody titer of virus, fungus, toxoplasmosis, antinuclear antibody, rheumatoid factor, and in chest X-ray if there is doubt of hilar lymphadenopathy, then you have to go for chest X-ray, CT, thorax, Mantoux test, then enzyme test for tuberculosis. You need bronchoscopy, bronchoscopic biopsy, mediastinoscopy, etc. Lymph node biopsy, this is the most direct approach. If the lymph node is palpable, we can do it by needle aspiration of the submandibular lymph nodes, here it is done, or we can take out the lymph nodes, this is called excisional biopsy, FNAC, fine needle aspiration, core biopsy, different types, different methods to collect material properly, and this leads to final diagnosis. Then which are the nodes you will choose for this biopsy. Out of the all lymph nodes, it is preferable to take largest nodes, and if possible avoid inguinal and axillary nodes. Supraclavicular highest diagnostic yield, this is a very good. So, largest node, and if available supraclavicular glands to be selected for this examination. Then after doing this biopsy, there may be complications like infection, hemorrhage, etc. So, we have to take up accordingly. So, we have discussed in short lymphadenopathy. Now, my subject is lymphedema. So, lymphedema, this is mainly related with transport problem of the lymphatic system. Lymphatic fluid transmitted from most peripheral part of the body to circulation, and if that road is blocked, there occurs accumulation of fluid lymph, and that leads to swelling of the part, that is called lymphedema. The lymphatic system, it works with the venous system for fluid return. Body is supplied with its nutrition and other things, and heart to artery to capillaries, and it diffuses to the tissues, and again 90% of the materials comes back to circulation in the venules and to venous system and drains back to heart. This 10% which is perfused in the tissues for their nutrition, supplying of nutrients and other materials, and collection of bad elements from the body, it is carried to the venous system back by the lymphatic system, and it removes plasma proteins, filters antigens, bacteria, waste products, produces white blood cells. The initial lymphatics, capillaries to venules, and in between that structure there lies overlapping the endothelial cells of the initial lymphatics, lymph capillaries. Lymphatic capillaries drains to pre-collectors. These are called afferent collectors. They are having muscular cell with valves, and that having valves at a separate distances. In between the valves, this area of the lymphatic system is called lymphangions. The valves produces resistance to the backflow of the lymph to the tissue spaces. Then it ultimately drains into the lymph nodes. There are approximately 600 lymph nodes in the body, out of which 300 are present in the head and neck region. And these lymph nodes, they perform important immunological functions and offers resistance to the flow of the lymphs than ducts. From the lymph nodes, the lymphatics are carried away by the efferent collectors to the lymphatic trunks, ultimately to the lymphatic ducts. There are two lymphatic ducts, right lymphatic duct and thoracic duct. Right lymphatic duct drains the head, neck, right upper limb, and the thoracic duct drains both lower limbs, whole abdomen, pelvis, chest, left upper limb, and then enters into the venous system in the junction of the internal jugular vein and left subclavian vein. This is the site. So, whole lymphatic system and drainage is divided into lymphotomes, watersheds, and anastomosis. Lymphotomes, they are the distinct regions of the body for fluid drainage. Watersheds, division areas between lymphotomes where direction of flow changes. You see, from the lower limb drains into the inguinal regions. In the abdomen, below the umbilicus, it drains into the inguinal region. Then from the chest, right side and left side, it drains accordingly. But there is anastomosis between the lymphatic channels. They are through collateral vessels offering alternate routes of drainage. So, if one route is obstructed, one lymph nodes obstructs the flow, then there may develop collateral channels. And this lymph fluid, nature of the lymph fluids, they are transparent yellowish fluid, 96% water, more dilute than plasma. Also consists of protein, lipid, minerals, hormones, cells, bacterial cells, cell wastes, etc. Body produces 2.4 liter of lymph fluid daily, 25 liter of lymph fluid cycles through the heart. Lymphedema, this is the pathology, this is what we are concerned. Lymphedema is the excessive accumulation of protein rich fluid in the tissues caused by a transport failure of the lymphatic system. So, I have told you earlier, failure of the transport system of the lymph to the venous circulation. There are so many causes which will be discussed, and that leads to accumulation, excessive accumulation of lymphatic fluids, and that causes lymphedema. Pathophysiology, mechanical insufficiency, lymphostatic low flow edema, low volume insufficiency, a breakdown in the transport capacity of the lymphatic system. This is mechanical insufficiency. Dynamic insufficiency, lymphodynamic, high flow edema, high volume insufficiency, high load placed on the lymphatic system exceeds its capacity, and combination of this mechanical and dynamic safety valve insufficiency. Causes of lymphedema. What are the causes? There may be primary or secondary. Primary causes, congenital deficit in the number and size of lymph nodes or its pathway. This is a congenital abnormality of the lymphatic system, and whole or part of the lymphatic system may not develop or hypodeveloped, and according to its deficiency it may present at birth. that is called Milroy's disease. A child may be born with edema at birth, or there may not be total insufficiency, partial, and it appears slowly, gradually, that is called lymphedema precox, appears at puberty, that is also called mixed disease, or it may present in adult life, that is called lymphedema tarda. And what are the secondary causes? Caused by removal or damage to lymph nodes and damage to pathways of the lymphatic supply. That may be due to diseases or iatrogenic, means caused by physicians and doctors. What are the causes of secondary? Cancer. Cancer spreads to lymph nodes and totally destroys its function and obstructs the channels carrying lymph. Or following cancer treatment, that is radiotherapy, that may damage the lymphatic system and obstructs the transport of the lymph. Or after trauma, mainly degloving injury of the limbs, where total avulsion of the skin and tissues occurs, and after treatment repair, that original function does not exist, and that may lead to lymphedema. Chronic venous insufficiency, example varicose vein. There is slowing or absence of venous return, leads to excess collection of lymph in the or fluid in the tissue spaces, and lymphatic system may not be able to handle so much of extra pressure, and that ultimately leads to lymphedema. Or paralysis, due to paralysis of different regions, there may be dysfunction of the transport system. And disease very common in our country is filariasis. So, when there is excessive collection of fluid in the spaces, there occurs chronic swelling, excessive tissue proteins, which brings fibrotic changes, fibroblasts are grown, and tissue is prone to have repeated infection called chronic inflammation, infections, cellulitis, and skin changes. Epidermis becomes thickened, keratin etc. grows more. So, there are different changes seen in the skin, starting from loss of crease, in thickening, elasticity, infection, etc. Now, what are the signs of lymphedema? Patient feels heaviness, fullness of limb, or puffiness. As it increases, edema increases, there comes stiffness in performing day-to-day life activity. Patient feels resistance in walking or doing other works. He feels weakness, fatigue, as the tension increases, he feels bursting feeling, pain, numbness, paresthesia, etc. So, what are the consequences? Functional deficit means his functional capacity decreases, loss of mobility, difficulty in wearing normal clothing, size does not match, and psychological issues, because this type of swelling, edema, it throws mental pressure and social difficulties, etc., which leads to psychological issues to the patient. Stages of lymphedema. Stage 0 is latent subclinical swelling not evident despite impaired lymph transport. This is latent, it is not easily recognized. Stage 1, completely and spontaneously reversible. When the patient takes rest or keeps the foot limb elevated, then swelling completely disappears. This swelling is soft and this edema is pitting edema. Little to no fibrosis, no thickening of the skin, skin easily pinched and moved. Stage 2, this is spontaneously irreversible, tissue usually fibrotic, means fibrotic changes has occurred. Pitting requires strong pressure, otherwise pitting sign is negative, or there may be no pitting, but it is reversible, it can be treated. Then stage 3, this is called elephantiasis. It is irreversible, damage has occurred, swelling never disappears, no pitting, significant fibrosis, skin has lost its elasticity, huge size, papilloma, hardening of the skin, etc. seen. So, what is the goal of the treatment? Immediate goal of lymphedema therapy is to relieve swelling, and ultimate goal is to enable the patient to self-manage and control this chronic condition. Complete decongestive therapy, manual lymphatic drainage, MLD, lymphatic drainage by manual pressure, or compression bandaging, exercise, skin care, this is very important. Compression garments, these are tailor-made hosiery garments which exactly fits and gives pressure more on the distal part and gradually pressure reducing, so that lymph flow from distal to central part is favored. And this treatment of this lymphedema is not easy. It needs a team approach. Only one doctor or surgeon cannot help. It needs help of the physician, specially trained nurses, other therapists, physiotherapists, then certified garment fitter, nutritionist, psychologist. Phase of treatment, phase 1, active intervention, attending therapy 2 to 5 days per week, compression bandaging 23 hours per day. So, in 24 hours 23 hours this bandaging should be maintained, only to be removed when the patient takes bath. Daily home exercise, self-massage, all are taught by the specialist and physiotherapist, and then patient has to follow it. Phase 2, this is also self-management. Transition to compression garments, specially made garments which gives compression so that lymph flows from distal peripheral part to central part. And diagnostic testing for this, these are the some lymphoscintigraphy, this is radiological isotope evaluation, lymphography, direct oil contrast, ultrasound assessment, presence of filarial worm, MRI, CT scan, etc. Skin and wound care is very important, and skin should be protected and keep moisturized. And if there is wound and infection, this must be treated first, followed by other methods of treatment. Manual lymphatic drainage. Goals of technique: increase peristalsis of lymphangian, break down fibrotic tissue, increase lymph volume in lymph vessels, decrease congestion in interstitium. Basic principles of treatment: treatment begins proximal to clear proximal lymphotome before moving to affected lymphotomes. Massage is directed towards the cleared lymphotomes. Pressure is very light stroke. Medical compression bandaging. Low stretch bandages provides low stretch when no contraction or higher compression when muscle contracts. Prevent refill lymphatics, work with muscle pumping, follow law of Laplace, the smaller the radius, the greater the pressure. Compression garments maintains reduction gained during therapy. Transition to garments when reduction plateaus. Garments of daytime wear, options for nighttime, insurance. Exercise facilitates muscle pumping, should be done with compression, progress proximally to distally, very low resistance, few repetition, rests are needed. Patient education is very important. Home exercise, self-massage, skin care, and precaution to prevent from other injury, infection, and any infection occurs, immediate treatment, compression garments. Now there is very few surgical operations which can help this disease, which is very advanced, and one is bypass operation. Means bypassing the obstructed area to the healthy area through omental pedicle, skin bridge operations, etc. Then another is liposuction. In chronic cases, there is excess lipid tissue, especially in the thighs. If liposuction is done, then some improvement occurs after using compression hosiery bandages for 1 year. Then limb reduction procedures, these are the names of operations: Sistrunk, Homan's, Thompson and Charlie's operation. In Sistrunk's operation, a wedge of skin is removed and subcutaneous tissue is also excised and it is closed primarily. It is very helpful in thighs. Homan's operation is raising of skin flap and then burying it to the redundant part, and one at a time, medial side of the leg, especially cuff region edema, then after 6 months another side is done. Thompson operation, this is also modification of the Homan's, and Charlie's operation, here there is total excision of the subcutaneous skin tissue and replaced by split skin grafting. So, these operations are done, but cosmetically not very effective. And there are some medications which are also used, flavonoids etc., but role is very controversial. So, lymphedema management is in short diagnosis, and initially it is a team approach and the patient often comes late. So, it is very difficult, but with the help of the other branches as described, some relief and prevention of the progress of the disease is possible. Thank you.